Now we're going to talk about muscle skeletal injuries and fractures. So we're talking about any kind of trauma to the muscles or the bone. All right, so what exactly are the causes? The causes can be cancer, it could be osteoporosis, it could be traumatic injury, like we're talking about penetrating trauma or blunt trauma. So these are so many reasons why muscle skeletal injuries or fractures can occur. All right, so assessments that we're going to be wanting to focus on are diagnostics as X-ray, CT, MRIs. That's what we're going to be seeing in these patients. So we're going to chunk this into different body systems that we're going to focus on, and then we can so we can understand clinical manifestations, interventions, and all that stuff as collaboratively. All right, so neurovascular, what we're going to see is we're going to want to be monitoring that sensation. Does the patient feel? Do they have motor function? And is there pain? So these are the things we're going to focus on when it comes to the nervous system, because the nervous system is innervating. Do we have motor function? Do we feel? That's like parallel. And then do we actually feel pain? So sensation and pain are very, very similar. Our peripheral vascular system, we're going to want to focus on is the color. What color am I? Do I look like I'm not cyanotic? The temperature, am I cold and am I warm? Capillary refill, is it less than 2 seconds or is it longer? An edema we're going to be monitoring for. So these are the things we're going to be focusing on when it comes to peripheral vascular. Is the next thing I want to talk about, is it closed or open fracture? A closed is the skin is intact, or is it like things are hanging out and crazy? So open, you see the bone. Closed is where you don't see the fracture actually inside of the body, but this is where fat emboli becomes super, super risky. So actually, it doesn't mean closed or open is better, one more than the other. They all have their own risks. So fat emboli is often associated with closed fractures, so be careful of that. Is the injury complete? Is it incomplete? So it kind of just depends. The fracture's directions have different classifications we'll briefly go over. And that's transverse. Transverse is like across like that. Spiral is like, it could be like spirally. Green stick is when we have our little splintered hanging out. So like there's like a little thing out and then like it kind of goes like this. So it's like literally there's a splint. Comminuted is when it's like little pieces like crushed. Like, I don't know how to explain it. You don't want to jam something and it all goes all over the place. So it's like little crushed areas. All right. And then oblique is that like sideways, but it's like it's still together. So this matters when you're trying to figure out interventions, because can we keep it aligned in a cast, or do we need to intervene with surgery? It's very important to know the different kinds. And pathologic, it could just be like they have osteoporosis and a risk for injury, or it could be stress where they go on their foot over and over and over again and stress injuries, so that can cause, and it's not as like, it looks different. So all these different kinds are just classifications that medical physicians use. It could be displaced or non-displaced. That's why we have to know the direction of the fracture. If the bone is like here, and then all of a sudden you need to get back here, you're going to need surgery to get that back in place. Whereas if it's already in line, you may be able to have interventions like a cast or immobilization to help it heal. All right. So we'll briefly go over the clinical manifestations we're going to see in these patients. We're going to have a loss of function. We may see deformities, edema, and swelling. We may see ecchymosis or contusions, and muscle spasms are also something, because we're going to think about medications when we're trying to prevent those muscle spasms. Because, you know, when you first have injury, you can have primary injury, secondary was the inflammation goes on too. Think about that. And pain and tenderness. It hurts. All right. So now we're going to talk about our interventions. What are we going to do as a nurse? All right, so the first thing that we probably want to think about is fractures. Immobilize it. Just stop it. Immobilize it. But you know what? Let's first think about immediate after injury. What do we think about? It's RICE. That's an acronym. Know it. R for rest. I for ice. I should know that. RICE. Rest, ice, compress, and elevation. Now I talked with Jennifer, my friend, and she was saying, so how are you going to compress this? It could be a cast, but it can also be those ACE wrap which can help with compression. So those ACE wraps that you put around can help with compression, but you want to really monitor that it's not too tight and distally from the compression, because it could cause acute compartment syndrome. So think about these things as you're going like around. All right, so other things. So now we know what we have to do immediately as a nurse. Like, think of the RICE acronym, know it, just know it. Our fracture immobilization is really, really important. We have different tools. They all have the same concept. The concept is immobilize the fracture. So rest, ice, compress, elevation. Rest stands for basically immobilize it, you know. We have our splints, you know, where just a sling or a brace or a immobilizer is an actual thing, a cast, and external fixators. So external fixators, what do we want to think about? We want to think about cleaning the sites with sterile water, and it has to be half strength hydroperoxide and or normal saline. So make sure it's half of it and like half strength. All right, so sterile gauze, we want to dry. You want to make sure the area is dry. And a cotton tip with batricin, it depends on the doctor's orders. So the doctor may order batricin, just be aware of that. You want to use cotton applicator tips to clean the area. And priority is to maintain sterility for external fixators, because think about it, there's like screws literally going into your bone from the outside. So we're at like super high risk of like infections. And do not get the area wet. Like, don't get it wet. I mean, there's so many things. Whenever you're thinking about infection and open wounds, you always want to think about not getting the area wet, because that like is like, you know, if it's wet, it's like bacteria party. So yeah, don't get it wet. External fixators, don't get the area wet. Remember that. And if they do have, by chance, an infection and things just don't go right, you want to teach those patients what they're even looking for. What exactly does an infection look like? If you don't teach the patients what an infection looks like, signs and symptoms, they may not know, like me. Because you know what? When I was a student, to be honest, I probably didn't know. So signs and symptoms of an infection. Yellow drainage, something's wrong. That's not supposed to be pretty. You may like the color yellow, but that's still like, that's what you're looking for. So yellow drainage is a sign of infection. What other things are we going to look for? Exudate. So exudate is the yellow drainage. That just means drainage. Erythema. What does that mean? Erythema is the swelling and redness you see at the site. Look for that. That could be a sign of infection. And pain. If these happen, if you have pain at the external fixators, erythema, exudate, let the healthcare provider know. Don't keep this to yourself. There's a high risk of infection. Okay. So other things to think about is nutrition healing. Get those patients to make sure they have adequate amount of magnesium. Why do you need magnesium? It helps the body absorb calcium, which is really important when we're facilitating healing for these patients' fractures. So vitamins B, C, and D. B is like your energy. C is like, you know, your immune system. D, you need it for calcium to be absorbed also. And protein. So basically, we're focusing on nutrition is really based on getting that bone to heal, and you have to make sure that your nutrition is adequate in order to get it to heal in the first place. You want to monitor your CSM. So what the heck does that stand for? I'm going to explain it to you. C stands for circulation, S for sensation, and M for motion. So circulation, what are we looking for? We're looking for, is there pulses? Are they warm? Are they cold? Are they absent? Is the capillary refill, is it less than 2 seconds? Is it not? That may be a problem. Distal to the end of the fracture is where you're monitoring, just so you know where you're looking for. It's past that line. So if you're fractured here, you want to look at the high end, you know, makes sense. Sensation is the pain unrelieved by narcotics. That may be a sign of compartment syndrome, so be careful of that. Also, the reason is that they would be unrelieved by pain would be for ischemic, because ischemic pain cannot be relieved. Other things to monitor for is, do they have motion? Can they, if they have no motion, that may be a problem with their curing. Like after, obviously, because you're supposed to immobilize immediately after it, but they're talking like post-surgery, cast, you know, they can't mobilize it, that may be a problem. All right, so there's like fancy tools that there is out there, just so you know. There's like electrical bone growth stimulation to help healing, which is pretty cool. And so fraction reduction. These are surgery options that are out there. Closed reduction, open reduction, and traction. So traction is basically, we want to focus on that buccal traction. You want to assess the skin every 2 to 4 hours. If you forget to assess, they're at risk for all those ulcers and not so much fun stuff. Because the traction is basically used to reduce pain, and it reduces the pain, and it maintains the length of the fracture, because it's like this thing where it slings and it like pulls your femur away. So like it's usually used for like, it's the leg, and your leg is like pulled away. So it keeps it pulled away because often it like when you're fractured, it may come in. So you're trying to make sure that it maintains the length of. And this is used, you want to keep the level at the heart. It's used pre-op and for like your proximal femur, for instance. It's often used in older patients, but preoperatively is where our focus is for the skin buccal traction, to keep it immobilized and maintain the length. All right, so closed reduction, that's just a term used for non-surgical manual of realignment. They're talking about our external fixators, our casts, our braces, splints, immobilizers, to keep it realigned from the outside. But hold on. So our open reduction, that's when we want to think about opening, like open reduction, opening your body, kind of makes sense. That's when you realign with surgical incisions such as ORIF, open reduction internal fixation. So you're opening your body like a surgeon to open the fixation and all that stuff. So makes sense. Use an x-ray to determine the correct placement, but this is really a doctor's job to do the surgery, but just you got to know how to take care of the patient after the surgery, so that's really important. You may be part of the surgical team as a nurse, whatever you choose. That would be fun to be on a team. So just you know what they're doing. There's obviously, if it's a hip surgery, there's posterior and anterior and all that fancy stuff. So now we're going to talk about drugs really briefly. Pre-op, there's always, they always use an antibiotic pre-op to prevent from infection. Cephalosporin is an example I have on my notes. Pain meds will probably be needed post-operatively, pre-operatively. In general, there's a lot of pain. Also, aspirin is really a good one to use because it reduces the inflammation, and inflammation is a big problem, and it would reduce inflammation, makes the healing slower. So you really want to reduce that. Make sure the patient has their tetanus immunizations. They may need that because that is very dangerous, and that is associated with dangers when it comes to fractures. So check up on their history because that is really important. Other things to think about are a muscle relaxer. Their carisoprodol, cyclobenzaprine, and methylcarbamol. These are all muscle relaxants of the CNS muscle relaxants. So I'm going to break it apart and tell you what to watch for with each separate one. Carisoprodol is contraindicated for patients with intermediate porphyria. This is just a random fact to know. They're all CNS depressants, drowsiness, dizziness, lightheadedness, all watch for that. And whenever it's CNS depressant, no alcohol or any concurrent use of CNS depressants. Methylcarbamol, there's a harmless reaction. Just let the patient know that your urine may turn black, brown, or dark green. It's just random, but just make the patient know that they shouldn't freak out because it's harmless effects, and that's okay. Cyclobenzaprine has anticholinergic effects, so that's interesting, and just know what your anticholinergic effects are. They suppress your parasympathetic system, so we think of suppressing rest and digest, which means the rest and digest is not working as fast. So we're going to think of our blurred vision, dry mouth, constipation, urinary retention, and photophobia. All right, so now we're going to talk about complications. So what are the complications we're going to be watching for? Infection risk, high infection risk. Remember those like external fixator things, that's a risk. Opening your body, that's a risk. So osteomyelitis you want to watch for. Venous thromboembolism is also the other risk when it comes to these things. So CDCs use them, enoxaparin, range of motion, all that. The next thing we want to worry about is, because remember I said that closed reduction is really associated with fat embolism. super important. Watch for it. All right, so what would be a sign of a medical emergency of fat embolism? We're looking for that petechiae on the chest or neck or under the eyelid too. That is a big sign of fat embolism because you're not getting oxygen. You're gonna see all these dotty, like bruising looking things. Something is wrong. Tell the doctor like right away, like that's an emergency. This can happen, like you'll be monitoring this for like 24 to 48 hours after the injury took in place. So that's basically like by the time the patient's like, what is this spotty stuff on my chest? You'd be like, okay, I'm gonna tell the doctor right away. Fat embolism, it can happen in the respiratory tract, which is like the most dangerous area to have happen. Just kind of like pulmonary embolism, except this is a fat emboli. It would be called like acute respiratory distress syndrome. They may have, so you're gonna be looking for chest pain, tachypnea, so you're gonna be breathing faster because you're not actually getting the oxygen, so your body's trying to compensate. Cyanosis, you may see cyanosis because you're turning blue, dyspnea, you're having difficult breathing, apprehension, you're freaking out because you can't breathe, makes sense. Tachycardia, your body's like freaking out also, thinks it has to go faster. You're gonna decrease arterial pressure because it's always opposite. And mental confusion, which is hypoxemia, which is the cyanosis basically. What are we gonna do for these patients? The main thing for a nurse to be aware of is emergencies, fluid resuscitation, that low blood pressure, you need to increase it because you're at risk for hypovolemic shock. Oxygen, hypoxemia, you need to give them oxygen. If oxygen is not good enough, you may need positive pressure ventilation help. Do little repositioning as possible, actually. So repositioning is actually a danger because you may be possible to, you need to prevent from dislodging more fat into the body. So just be aware of that. So let's talk about the other complications to think about. So crushing syndrome. This is like a big thing to watch for when it comes to these fractures and in like really traumatizing. All right, because if crushing syndrome is not solved and you see crushing syndrome, it may result in amputation. So rhabdomyolysis is associated with crushing syndrome. Just think crushing, your cells are bursting like balloons and things are falling out of it. Like it's myoglobin's out and like your potassium just falls out of the cell. Myoglobin is coming from is basically what rhabdomyolysis is. So rhabdomyolysis is basically when damage to the muscle cells. So you're gonna wanna make sure to hydrate. So you need to hydrate because the myoglobin that is getting released from the muscle cells is actually going to lead to kidney failure. So make sure you hydrate those patients. If you suspect rhabdomyolysis from this crushing syndrome, look at those creatinine levels, the creatine kinase levels, which in males, the normal is 50 to 204. In the females, it's 36 to 160 units per liter. So again, I'll say it one more time. Normal creatine kinase levels. Creatine kinase is associated with what? Muscle damage. So if it's, what you're gonna be looking for in muscle damage is if it's double the amount of normal, that's probably a sign of muscle injury. And the teacher said something about, she has seen like creatine levels as high as like 30,000. That's way beyond normal. So yeah. So our normal creatine levels for males are 50 to 204. Let me say it one more time, 50 to 204 units per liter. For females, 36 to 160 units per liter. So it's a little lower in women and a little higher in men. Makes sense. 50 to 204 units per liter and 36 to 160 units per liter. All right, what are the things that we're gonna monitor for because of that kidney failure? Monitoring I's and O's, urinary output. They may have anuria, kidney failure, oliguria, low urine output, and it may be red. So that monitor for your urine. Also because of this crushing syndrome, cells bursting, potassium falling out. This causes acidosis when the potassium is hyperkalemia, heart problems. Your heart is irregular beats, so that's really dangerous. So what are you gonna give the patient if this happens? The doctor's probably gonna prescribe what? K-Xylate. So that's gonna get rid of that. And remember, hydrate. K-Xylate and hydrate, you're gonna see irregular heartbeat. All right, so the next two things that, oh, one more thing before I go on to the next topic is rhabdomyolysis is also caused by fungals like ketoconazole, the zoles for fungals, and atorvastatin. So that can also cause muscle injuries. All right, so amputations. So amputations, if this is not treated, crushing syndrome can result in amputations. So can compartment syndrome, actually. So amputations is a big thing. So what are the causes of amputations? This could be a motor vehicle accident. This can be from peripheral vascular disease, diabetes mellitus, and infections. A lot of reasons. So there's a lot of reasons why amputations may be needed, and it's really sad. These patients need help coping, and especially if they're not prepared and it's like an emergency situation, they're gonna have a really hard time coping after the surgery because it was like they didn't get time to like get accustomed to the idea. Diagnostics we're going to be looking for these patients. If it was a peripheral vascular reason, duplex Doppler, venography, arteriography, your RW, if it was infection reasons, our white blood cell count and differential. All right, so what are our interventions? So it's mostly interventions that are associated with post-op, because beforehand we're trying to prevent amputation from happening or preparing them for amputation, like psychologically. We're going to monitor after the amputation for monitoring their skin. Active range of motion help, because it's the most common debilitating would be contractures of the hips. So you want to make sure to get those patients to lay on their abdomen 30 minutes a day for 3 to 4 times a day on their abdomen. Get their hips to extend. So if you're laying on your tummy, your hips are extending, especially if they're like below the knee amputation, and you may need to help them. Remember that. So while in the prone position, avoid sitting in a chair for more than an hour with hips flexed, because that can cause risk for contractures. Also teach the patients to avoid dangling at the bedside, limb over the bedside, to reduce edema. You may have to teach them how to use a walker. This may be very new to them. Prosthetics. If it's for lower the strength of the upper body, you're going to have to get them to build up their strength, teach them how to build their strength. With their upper body, a hook is really the only functional option. Remember to teach them to clean with mild soap. Teach to not get leather or metal wet, and physical therapy and occupational therapy will be collaborative help from the nurses as well when it comes to prosthetic uses. Active range of motion, we talked about that. Shrinker socks. So shrinker socks is the figure 8 method for above the knee amputation. Make sure they're washed and changed daily. Compression bandage reapplied several times a day. They're worn at all times except during physical therapy and bathing. All right, so compartment syndrome is the other complication that we are worried about when it comes to fractures. Let's just define it real quickly. So it's a limited space and swelling that compromise function on the blood vessels, nerves, and tendons. So basically it's pressing onto the blood vessels, the nerves, and tendons from the surrounding space. Acute compartment syndrome pain is unrelieved even with narcotics. That's the main thing. So we want to look for that ischemic pain. So pain unrelieved by pain narcotics is due to that ischemic pain. And what are we looking for? Now, I should have said this in the beginning for assessments, but the 6 Ps are super important to monitor. So what does 6 Ps mean when you're talking about assessments? We're looking, and one of these 6 Ps actually has to do with compartment syndrome. So pain, because it's painful. Pallor, that means they're not getting enough oxygen to that specific area. Paresthesias, random tingling. Pulse, do they even have like a pulse in that area? That's good to know. Paralysis and pressure. Pressure, that's when we're talking about compartment syndrome. Is there pressure in that area? So pain, pallor, paresthesias, pulse, paralysis, and pressure. Pain, pallor, paresthesias, pulse, paralysis, and pressure. So that's what we're looking for. Now, if this is unrelieved, there is a surgical option to open up that area, and it's called fasciotomy. It's a fasciotomy. So in the textbook, it looks like little stitches in the area to help it seal, and I'm gonna explain, like it opens up the area so there is room in that area. It doesn't look pretty. And we should probably talk about what are the causes, so you try to avoid these causes. The causes can be restrictive dressing. So when it comes to fractures, you really want to avoid making it too restrictive, make sure it's not too tight. The other cause besides restrictive dressing from like a cast or splint is bleeding into the area, inflammation. That's why we want to give like aspirin to reduce that inflammation, and edema to the area, so like venous pooling and yeah, so that peripheral vascular area. So that's everything that talks about when it comes to our fractures. And fractures aren't fun, but you got to know what to monitor for, and these are the basics for adults and pediatrics and any patient there is out there, how the body reacts. So yeah, good luck on the test. Happy studying.